Hi everyone, my name is Shawin Vitsupakorn and I'm a rising sophomore at Duke planning to study global health and neuroscience. This summer, I had the opportunity of being a Huang Fellow and an intern with the Margolis Center for Health Policy. My work would not have been possible without my mentors Wenhui, Ipchida, and Gavin, as well as the rest of the team at the Center for Policy Impact in Global Health. I also want to thank Dr. Waitskin, Dr. Grunwald, and Dr. Krenzer, who led the Huang Fellows program. Okay, let's dive straight into my project. My research centered on India's Pradhan Mantri-Jan Arogya Yojana scheme, or PMJ for short. First, some context on India. As of 2020, it's classified as a lower middle income country, and it has the world's second highest population. For the past few decades, there has been a shift from communicable to non communicable diseases. The poverty rate is highest in South Asia, and the government health expenditure has historically been low. India delivers health services a bit differently between rural and urban areas, but they both follow three-tiered models, which you can see here in the bottom two pyramids. In the top pyramid is Ayushman Bharat, a program that seeks to revolutionize care by consolidating these two structures into a more comprehensive one. So, what is PMJ and why is it so important? In 2008, the government first launched RSBY, a scheme that provided insurance coverage to families below the poverty line. Still, many households were spending most of their income on healthcare and in some cases being driven to poverty. So in 2018, India unveils PMJ, which is an arm of the Ayushman Bharat program. A key difference between PMJ and RSBY is that PMJ's cover is nearly 17 times that of RSBY. The goal of my project was to evaluate the progress of PMJ in three dimensions. 1. Who is covered? 2. Which services are covered? And 3. Has the scheme offered financial risk protection? In terms of methods, I started off with a broad search of academic journals and gray literature. I then analyzed data from the official PMJ channel, and finally I conducted a narrative review. It's almost a 2-year anniversary of PMJ, so this timeline just showcases some milestones thus far. I want to point out two in particular. In October 2018, the government scaled PMJ up to 32 of the 36 states and union territories, and in December of 2019, they revised the health benefit packages from version 1.0 to 2.0. Alright, so has PMJ been effective according to the three dimensions I mentioned before? We found that the eligibility criteria are not fully inclusive. For example, the state of Meghalaya has a 12% poverty rate and 62% of its population qualifies for PMJ. In Uttar Pradesh, the poverty rate is over 2 times Meghalaya's, but only 38% are eligible. Furthermore, fewer beneficiaries are identified in states that have not operated insurance schemes before PMJ. Now for service coverage. PMJ itself provides over 1,350 packages, but it does not include outpatient care. Beneficiaries can access services free of charge, but only at hospitals registered in the PMJ network. Unfortunately, the empanelment of these hospitals is uneven across states. Lastly, let's look at financial risk protection. There have been many high-value claims under PMJ, which does suggest that the scheme has encouraged people to seek services that would have otherwise been too much of a financial burden for them. However, a case study in one state noted that PMJ has not significantly reduced out-of-pocket or catastrophic health expenditure. This graph here shows just how varied service utilization is across India under PMJ, and this might be a symptom of deeper issues. For example, poorer states usually have less purchasing power and in turn may not attract health sector development. Overall, PMJ has seen great successes and challenges so far. It aims to cover over 500 million people. That's more than the population of the US, Mexico, and Canada combined. It's a major step toward universal health coverage for India, no doubt. However, the skewed distribution of resources means disproportionately less enrollment and access in poorer states. Even with the high insurance cover, outpatient expenses are not included, and these make up the bulk of India's out-of-pocket expenditure. As for quality, beneficiary feedback has largely been positive, but the private health sector, which delivers many services, is not well regulated. Now, what implications does our research have on policy? India should consider impaneling more of its public sector and raising awareness of the scheme at the community level. Given the disparities across the country, we recommend building capacity for less resourced states, whether that be strengthening the databases used to enroll beneficiaries or more recruitment of health workers. Perhaps coverage can be extended to outpatient services and regulations established nationwide. Lastly, India should support health technology assessment to make sure that policy decisions are backed by data and informed by the broader community. As for next steps, I will be identifying potential lessons from Thailand, which, when it first rolled out universal coverage, was also a lower middle income country. This project is part of our center's mixed methods study on PMJ performance in Uttar Pradesh as well. Thank you so much for listening. If you have any questions at all, I'd be more than happy to chat, so don't hesitate to reach out.